Pectoralis Major. The pectoralis major is a flat, fan-shaped muscle located on the superficial aspect of the anterior thorax. It is covered completely by the clavipectoral fascia, which is attached to the inferior aspect of the clavicle and the sternum. This fascia continues on the lateral side as the axillary fascia, which connects the pectoralis major with the latissimus dorsi and covers the adipose axillary tissue. The pectoralis major has three portions: the clavicular head, which originates on the anterior edge of the medial half of the clavicle; the sternocostal, also known as the transverse or the sternochondral. It originates on the anterior aspect of the sternum, the lateral aspect of the first 6 chondral cartilages, and the 7th rib. The deep fascicles of the pectoralis major originate on the cartilage of the 3rd, 4th, and 5th ribs. And last, the abdominal portion. This is inconsistent and originates on the sheath of the rectus abdominis and the ribs distal to the 7th rib. All of the rib fibers coalesce into a U-shaped tendon that attaches to the crest of the greater tuberosity. The clavicular portion attaches distally and forms the anterior portion of the tendon, while the posterior portion of the tendon is formed by the sternocostal and abdominal fascicles. The clavicular and superior sternocostal fibers flex, adduct, and internally rotate the arm. The clavicular fibers also suspend the humerus. The sternocostal fibers adduct, horizontally flex, and internally rotate the arm. They also contribute to shoulder protraction. The inferior sternocostal fibers and the abdominal portion adduct the arm from the abducted position. They also contribute to inspiration through their costal and sternal attachments. The pectoralis major is innervated by the medial and lateral pectoral nerves. The medial pectoral nerve arises from the medial cord at the level of the clavicle. It runs obliquely in an inferior and medial direction in front of the axillary artery and through the clavipectoral fascia and the pectoralis minor muscle, dividing into several branches for the pectoralis major muscle. It innervates both the major and the minor muscle. The lateral pectoral nerve. This arises from the lateral cord at almost the same level as the medial pectoral nerve. The lateral pectoral nerves give a branch that anastomoses with similar branches from the medial pectoral nerve. The deep branches of the lateral pectoral nerve reach the pectoralis minor muscle, and some of them perforate this muscle to innervate the pectoralis major. The deltoid muscle. This is a multipinnate muscle that is triangular, with its origin at the base of the triangle and its attachment at the vertex. It covers the entire shoulder region and is covered by the deltoid fascia. 3 portions can be distinguished based on the origins of the fibers. There's the clavicular, the acromial, and the spinal. The clavicular portion originates on the anterior edge of the lateral third of the clavicle and is separated from the clavicular fibers of the pectoralis major at the deltopectoral triangle. The acromial portion originates at the lateral edge of the acromion and continues with the clavicular portion without clear separation. The spinal portion originates at the inferior edge of the spine of the scapula. The origin is a flat aponeurosis with a smaller anterior aspect and a larger posterior aspect. All portions converge to a V-shaped attachment at the deltoid tuberosity of the humerus. The subdeltoid bursa is located between this muscle and the articular capsule for the glenohumeral joint, which may communicate with the subacromial bursa. The clavicular portion of the deltoid flexes and internally rotates the arm. The acromial portion abducts the arm beyond 30 degrees. The clavicular and spinal fibers also contribute to abduction. The spinal portion extends and externally rotates the shoulder. The deltoid is innervated by the axillary nerve, C6 to C8. The axillary nerve arises from the posterior cord of the brachial plexus and the axilla, in front of the subscapularis muscle, and then continues to the region known as the quadrilateral space, where it turns posteriorly. In this area, it gives off a motor branch to the Teres Minor. Next, it runs on the surgical neck of the humerus, intimately close to the joint capsule. Through this course, the axillary nerve innervates the deltoid muscle and conveys the sensory information from this region through the superior lateral brachial cutaneous nerve. The supraspinatus. The supraspinatus is a short muscle that originates from the supraspinatus fossa of the scapula. Its fibers converge and pass beneath the subacromial space formed by the acromion and the coracoacromial ligament. The subacromial bursa is located between its roof and the muscle. This is a common location for impingement. The tendon attaches to the facet of the humeral greater tuberosity. The main role of the supraspinatus is to abduct the shoulder. When the shoulder is in approximately 70% abduction, the greater tuberosity is in contact with the acromion. To avoid this bony block, other muscles externally rotate the humerus to allow the arm 180 degrees of abduction. The supraspinatus is innervated by the suprascapular nerve, C4 to C6. The suprascapular nerve arises from the superior trunk. Sometimes it can arise from C5 with some fibers from C4. It courses in the lateral and dorsal directions to the scapular notch, where it passes beneath the superior transverse ligament of the scapula to reach the supraspinatus fossa and innervate the supraspinatus. From there, it continues to the spinoglenoid notch between the inferior transverse scapular ligament of the scapula to reach the infraspinatus fossa, innervating the infraspinatus muscle. Some branches reach the posterior articular capsule. The infraspinatus. The infraspinatus is a flat muscle that originates at the infraspinatus fossa. The muscle fibers coalesce into a tendon that is intimately attached to the glenohumeral capsule. The tendon is attached to the middle facet in the greater tuberosity of the humerus. The main function is to externally rotate the arm. It is innervated by the suprascapular nerve, C4 to C6. The Teres Minor originates from the superior aspect of the lateral edge of the scapula. This tendon is also integrated with the fibers of the posterior glenohumeral capsule. It inserts on the inferior facet of the greater tuberosity. When the Teres Minor contracts, it tightens the posterior aspect of the capsule, externally rotating the arm and avoiding impingement. It also acts as a dynamic stabilizer. The Teres Minor is innervated by the axillary nerve, C5 to C6. The axillary nerve arises from the posterior cord of the brachial plexus and the axilla, in front of the subscapularis muscle, and then continues to the region known as the quadrilateral space, where it turns posteriorly. In this area, it gives off a motor branch to the Teres Minor. Next, it runs on the surgical neck of the humerus, intimately close to the joint capsule. Teres Major. The Teres Major originates from the inferior facet of the lateral edge of the scapula, which is separated from the infraspinatus fossa through a small oblique crest. The fibers ascend obliquely in an anterior direction to attach through a flat tendon into the crest of the lesser tuberosity. The Teres Major acts to generate adduction, internal rotation, and slight arm extension. When the arm is fixed, the Teres Major tilts the scapula so that the inferior angle is positioned laterally. The Teres Major muscle is innervated by the inferior branch of the subscapularis nerve. The lower subscapular nerve branches off the posterior cord of the brachial plexus. It then travels distally to innervate the inferior aspect of the subscapularis muscle and the Teres Major. Some branches innervate the anterior aspect of the articular capsule. The Subscapularis. The subscapularis originates on the subscapularis fossa. The fibers coalesce into a tendon which interdigitates with the glenohumeral joint capsule. The subtendinous bursa is located close to the glenoid. The subscapularis tendon acts as an anterior capsular reinforcement. It also tightens the capsule during internal rotation. The fibers insert on the lesser tuberosity of the humerus and the proximal aspect of the lesser tuberosity crest. The subscapularis is innervated by the upper and lower subscapular nerves. The upper subscapular nerve emerges from the posterior cord of the brachial plexus and then lies on the subscapularis muscle, which it innervates. Coracobrachialis. It originates from the apex of the coracoid process and shares its tendon with the short head of the biceps. Therefore, this common origin is sometimes called the conjoined tendon. The coracobrachialis separates from the biceps at the proximal third of the humerus. It attaches on the anteromedial aspect of the upper third of the humerus. The bursa for the coracobrachialis muscle is interposed between the coracobrachialis and the subscapularis, which lies beneath. The main function of the coracobrachialis is to take the arm into its resting position. It is also very important for suspension of the arm. The coracobrachialis is innervated by the musculocutaneous nerve, C6 to C7, which perforates the muscle proximally. The musculocutaneous nerve is the terminal branch of the lateral cord of the brachial plexus. It is a motor nerve at the arm and a sensory nerve at the forearm. It originates at the axillary region, approximately at the level of the pectoralis minor muscle and lateral to the median nerve. The musculocutaneous nerve enters the body of the coracobrachialis about 5 to 8 centimeters distal to the muscle's origin at the coracoid process. It sends branches to the muscles, the humerus, and the anterior aspect of the elbow joint, being responsible for the innervation of elbow flexors. At the mid portion of the arm, the musculocutaneous nerve sometimes forms an inconsistent anastomosis with the median nerve. Finally, the musculocutaneous nerve emerges lateral to the distal biceps tendon and transforms into a cutaneous nerve, the lateral and a brachiocutaneous nerve. Now, for some arteriography. Some of the